Hemothorax, review. Hemothorax has been consistently defined as a collection of blood in the pleural space or a pleural fluid hematocrit of greater than 50%. A hematocrit value of pleural fluid below 50% does not necessarily rule out hemothorax. A hemothorax may become diluted with pleural fluid in as little as 3 to 4 days, mimicking a hemorrhagic effusion with a hematocrit between 25 to 50%. Grading hemothorax, intrapleural blood less than 400 ml is classified as a minimal hemothorax, while 400 ml to 1000 ml is a medium hemothorax. Anything greater than 1000 ml is considered a massive hemothorax. Traumatic hemothorax can be due to either blunt or penetrating injury. Thoracic injuries occur in approximately 60% of all polytrauma cases and are responsible for 15 to 30% of all trauma mortalities. Gunshots and stabbings are the primary means of penetrating thoracic trauma, whereas 70 to 80% of blunt thoracic trauma is caused by motor vehicle crashes. While blunt thoracic trauma typically occurs far more frequently, mortality is significantly higher in penetrating chest trauma, with up to 90% not surviving transport to the hospital. Iatrogenic hemothorax occurs during surgery or procedures when the lung parenchyma, surrounding vessels, or organs are inadvertently damaged. Thoracentesis, central venous catheterization, tube thoracostomy, and thoracotomy. Spontaneous hemothorax. The most common cause of spontaneous hemothorax is spontaneous pneumothorax. Coagulopathic etiologies consist of congenital diseases such as hemophilia or thrombocytopenia, or occur with therapeutic anticoagulation. Vascular origins are due to rupture or dissection of the descending thoracic aorta in patients with atherosclerosis or uncontrolled hypertension. Genetic diseases such as Ehlers-Danlos syndrome and Rendu-Osler-Weber syndrome, neoplasia, costal exostoses, endometriosis, pulmonary sequestration, infections, pulmonary infarction, pancreatitis, tubal pregnancies, and extramedullary hematopoiesis. Chest X-ray has traditionally been the initial tool in the emergency room for rapid evaluation of thoracic injury. Upright CXR is preferred, because in the supine position the blood will be distributed along the entire posterior aspect of the affected pleural space rather than the diaphragmatic surface. The focused assessment with sonography in trauma (FAST) is a bedside test for use in acute trauma patients to rapidly assess for intra-abdominal hemorrhage and to rule out clinically significant pericardial tamponade. The extended focused assessment with sonography in trauma (EFAST) adds additional views of the hemothoraces to look for signs of pneumothorax and hemothorax. Once stability is achieved, a chest CT, preferably with intravenous CT scan contrast, can be performed to evaluate further pathology in detail. Acute hemothorax, early management. Early identification of patients at risk for hemothorax following trauma significantly decreases morbidity and mortality. Life-threatening injuries require prompt attention either by thoracostomy or, in severe cases, thoracotomy. Appropriate management of any patient with suspected hemothorax depends on their hemodynamic status. The Advanced Trauma Life Support course, sponsored and updated by the American College of Surgeons, provides practitioners with guidelines for the appropriate management of chest trauma, including hemothorax. Delayed hemothorax is any hemothorax that occurs after negative initial imaging regardless of elapsed time. Rib fractures are the most common cause of delayed hemothorax and are reported to occur in 30 to 80% of patients with thoracic trauma. Some investigators advocate surgical fixation to improve outcomes in terms of respiratory failure and delayed complications such as recurrent and retained hemothorax, and chronic pain. Retained hemothorax has been defined as blood occupying at least 1/3 of the pleural space which cannot be drained by thoracostomy after 72 hours or clots of at least 500 ml volume. Retained hemothorax can begin to form as early as 24 hours after chest tube placement. The incidence of retained hemothorax is estimated between 5 to 30%, based on the results of multiple studies, of which a large percentage requires surgical evacuation. The consequences of RH include fibrothorax, trapped lung or high rates of the development of subsequent empyema.
Management: conservative thoracentesis, tube thoracostomy, intrapleural installation of fibrinolytic therapy, VATS, exploration thoracotomy.
Conservative management: if the patient is hemodynamically stable, and the hemothorax is confirmed to be less than 300 ml, conservative management with observation, aggressive respiratory care and pain control can be attempted. If observation is elected, it is suggested that early and frequent imaging (CXR) be repeated during the first 24 hours to ensure stability of the hemothorax and to detect any other potential pathologies. Volumes greater than 260 to 300 ml were up to 4x more likely to require drainage. Thoracentesis is still often used to diagnose new-onset pleural effusions suspicious for malignancy or infection. At present, needle aspiration for the treatment of hemothorax is considered obsolete, though small, clinically insignificant collections may still be treated with needle thoracocentesis. Thoracostomy tube: according to International Practice Management Guidelines, all hemothoraces regardless of size should be considered for tube thoracostomy. All tube sizes as small 14 FR have been compared to 28 FR tubes and found to have similar performance. Recent studies suggest that initially placing the chest tube to suction rather than water seal may be associated with improved outcome regarding duration of chest tube therapy, length of hospital stay, persistent air leak, and risk of empyema. Chest X-ray should be repeated after tube insertion to confirm the proper position. Re-evaluation of the patient and monitoring of chest tube output should be done every hour for the first 24 hours after installation. Drainage from the hemothorax should in general be less than 100 ml in 24 hours before removal of the chest tube. Video-assisted thoracoscopic surgery. A major limiting factor of VATS is that the patient must be hemodynamically stable. The patient can be actively bleeding during VATS as long as they remain hemodynamically stable. The timing of VATS is also very important when evacuating a hemothorax. Within 48 to 72 hours, VATS is usually successful for hemothorax evacuation and allows for early re-expansion of the lung with reduction in short and long-term morbidity and mortality. Thoracotomy: if the patient is actively bleeding into the thoracic cavity and remains hemodynamically unstable despite initial attempts at resuscitation, thoracotomy is the procedure of choice. Thoracotomy has a reported incidence of 2.6%–6% in all chest trauma cases. In chest trauma cases involving hemothorax, thoracotomy has been reported to be performed 10% of the time, especially in patients with penetrating chest trauma. If the patient presents in shock, has a chest wall defect, airway obstruction, tension pneumothorax, pericardial tamponade, or flail chest, emergency thoracotomy should be performed. Significant output from a chest tube is also an indication for thoracotomy and is defined as 1000 to 1500 mls total in 24 hours or 200 to 500 mls per hour for 2 to 3 consecutive hours. Specific internal injuries may also be indication for immediate thoracotomy, including esophageal injury, diaphragmatic injury, cardiac injury, massive hemothorax and great vessel injury. The standard approach in emergent thoracotomy: anterolateral, clamshell and hemi-clamshell. Contraindications: severe blunt trauma and shock patient. Emergent thoracotomy not be performed in patients with no signs of life upon arrival to the hospital. Severe neurological insult. Thank you for watching.